I wish more women knew that pelvic floor therapy in general is not scary. I think there's a lot of people who don't start because they think it's going to be weird, or they think, oh, it'll just go away, or, whatever. They get scared because of the hype or things that they've heard about. And that may not be their experience at all, especially if they're seeing someone who truly is treated like that. This is all I see, versus somebody who just does a little bit and dabbles. So that would be the one caveat there. See somebody who truly specializes. They're never going to force you to do something you're not comfortable with. They're always going to have your best interest in mind. They're normally, not that I toot my own horn, but very personable people who they don't love what they do. They're not going to be specializing in it. They're not going to be doing it, right?
So thank you guys for being here. I know we're just coming out of a holiday. Probably some of us are still coming up for air with family, maybe still have family around, and you're here to honor yourself for an hour and take time to learn and grow and be amongst like-minded women, which is amazing. I'm excited today because I get to have Dr. Sarah Tilley here. And the way that we met, just a quick backstory, is she was a member over at Venus and was coming in and doing strength training. And, when you're in proximity with women in strength training, you get to know a little bit about them. And Sarah was always unapologetically speaking about women's bodies parts, like in a very medical way. And I'm like, I'm collecting this human. She's amazing. And so I knew, that there was going to be instances where I wanted to have her discuss certain topics. And this is another one of those days. She's been on the podcast. So thank you for joining us today, Dr. Sarah.
Thanks for having me.
I appreciate you. And I think a great place to start is, and where I like to start, is really just sharing with everybody where your journey has taken you to land you where you're at now, where you're helping women with pelvic floor dysfunction and probably so much more than just that. But, why did you choose this profession, and how is your story, sort of intermeshed with all this? Because usually there's a deep story there.
Yeah, great question. I won't go too far into the weeds, but
we like the weeds.
Ooh, good. Okay, weeds, good. Perfect.
Yes.
So I originally went into my doctoral program, PT program, with no idea that this existed. Zero idea. It's not like a really common thing. It's becoming more common, but it really wasn't on my radar at all. So while I was in school, I found out about it, took a couple weekend optional courses, and I said, I want to do a rotation in that. So I did, and I went for four months in one of my last years as a clinical experience treating patients. And I was like, ooh, this is kind of cool. This is really personal. It's not therapy, like mental health therapy, but it's really personal work. As you may imagine, when people come in with all sorts of pelvic dysfunction, they're like, who else do I talk to about this? And I said, I really like this. It's hybriding the physical nature that I love about PT, but then it brings in this extra deep layer with women. And at that time I was seeing men also. So fast forward a little ways, finished school, working orthopedically, decided, you know what, now's my time. I didn't have kids and I'm going to get my specialty. So I did that and kind of really focused in fully on pelvic floor patients, 100%. Then I got pregnant. Well, I went through a fertility journey to get up to that point, got pregnant, and I was seeing you during that journey. And I was so sick out of my mind. I couldn't even function in life. So I had some pretty severe nausea and vomiting during that journey. And I said, I need to figure out a way, not necessarily in the middle of that, but kind of after I made it through that, I need to figure out a way to access and treat women who maybe have kids or have a job that doesn't create access, or live in an area that doesn't have someone who can help them, which is still really common. There's not that many of us. I just want to make that possible. So out of that became my vision to start my own business, which kind of led me into where I am now in treatment. I don't live in California anymore. I live in Oregon. I live in Central Oregon, which is amazing. But I still treat patients from both virtually from California and in person here. So I just love it. I know it's kind of weird to talk about in that way, but I love talking about all that personal stuff for people. It's like sex topics, leakage, constipation, bowel issues. I'm getting a patient right now. I just saw it today who's fitness. She does all the strength work, bikini shows, which is not my wheel. I'm I don't know the terms for those things, and she has some really not great bracing strategies because of just how her body's developed. So she's got some really interesting core mechanics we've got to try to shift around. So it's just really fun to see the different patients that come in that may not fit what people think of as pelvic floor issues, like peeing their pants, which is definitely a problem. But I just love that it's really open and it allows me to see everything. So
yeah. There's, again, I have some notes and things, and I've been thinking about this conversation and how it applies oftentimes to the women that are listening, obviously the women here in this membership group. And I think for me, my curiosities lie when someone's thinking about oh, whether they have a weak pelvic floor or they are having issues with that. Like, what are some of the reasons people actually would seek you out? I guess
Mm.
would probably be one of the great places to start.
Okay, so I'm going to interpret that question. You tell me if it's not where you were going, as kind
Yeah.
of common things that cause people to go to pelvic floor PTs, correct?
Yes.
Okay,
Mm-hmm.
so the big guns, I guess the larger ones are going to be I pee my pants with coughing, sneezing, laughing, jumping, lifting, whatever those things are. I have really significant urinary urgency or urge incontinence, which means I need to go to the bathroom all the time. I have tiny bladder syndrome, as people say, which
Mm-hmm.
isn't a thing. It's not real. So I have to pee really often and I can't control it when it gets too severe. So I have to run to the bathroom. Right. So that's pretty
Mm-hmm.
common, including nighttime peeing that might hybrid into that space too. So we call that nocturia. So those are some on the urinary side. It could also be pain conditions related to the bladder, which is pretty common too. So bladder pain or referred pain coming out of the bladder into the abdominal area, pain with sex or pain with pelvic exams, any type of penetration, or it could be even wearing underwear. So some people are really sensitive to even like tighter fitting clothing. So they wear like loose boy shorts or loose pants. And then
Mm-hmm.
constipation or any type of bowel thing, which isn't as exciting to talk about for people, but it's really actually quite common, especially the constipation side. Some people on the other end. And then another big bread and butter would be like pregnancy, journey, birth, postpartum care, and that type of thing. Those are the big ones. There's plenty of
Mm-hmm.
other we could get into the weeds on, but that's probably the most significant.
What do you see most women over 40 coming in with? I would assume it's probably the
Mm,
a mixture of things, but
it's a
I'm getting,
mixture.
yeah, I'm really thinking more about the women who are just don't think it's really a problem. Like they think it's just
Mm-hmm.
normal. Like, oh, I should, it's just a part of aging. What do you consider like this is when you should probably be looking at getting some help? It's
Some
gone
interesting
too
ones.
long.
Yeah, I have some interesting ones. Okay, so one would be I just pee a little. That's a pretty common one. Like, oh, it doesn't really impact me unless I have a fuller bladder and then I laugh really hard. So it's only occasionally, like the little bits, or I'm lifting extra, I'm on a run and I have a little bit of pee sometimes. Okay, so like the little bits are still a problem. The other would be people who say, oh, I've always had a small bladder. Right. So it's always been there. So that's definitely something. But to get a little bit more interesting with the 40 plus age, which I am not quite to, but close to, would be this hormone shift that we have at that time frame. So with that,
Mhm.
we all know about perimenopause, menopausal symptoms, etc. I can't treat those symptoms. But what I do notice is women who, not all women, but some women have a change in vaginal dryness, which
Mhm.
can be a precursor to intercourse pain or any type of penetrative pain, which can also lead to sometimes bleeding. If the tissue gets really thin, they can have bleeding in the area. It could be labial bleeding, vulvar bleeding, etc. It's like, what's going on here? Why do I have blood? Why am I sensitive in this space? If a younger lady is listening in on this and you've had a baby, think to your postpartum vulvar area, how it gets kind of pale, less plump. It's just less exciting. Maybe orgasms are more difficult. Urinary control can become more difficult. That's also really common in this hormone shift into menopause. So if we're seeing those types of changes, even if they're small, it would be the time to say, "Ooh, what can I do to get ahead of this so I'm not stuck?" Because they're normally progressive symptoms, as they just
Mm.
worsen with time. So how can I get ahead of that so I'm not experiencing those things?
That makes perfect sense. Now, when you have somebody, like, let's just say, starting with the, like, I'm going to speak for myself, like, feel free, no shame in my game, but I'm like, I feel like I have the world's tiniest bladder. I'm going to be one of those
Mm.
people. How do you discern? My sister's like, yep, we can't go 5 minutes down the road without you having to pee 30 times. How do you discern what's excessive and what's not? Is there like some kind of standard for all of us, that have to pee every 10 minutes, it feels like?
Yes, there is. Well, I wouldn't say there's a standard. We look at a lot of factors when it comes to bladder. So the bladder has a typical, unless there's some sort of anatomical dysfunction, which is not very common, somebody who's had cancer or they're scarring or something. But for most normal anatomy people, the bladder has a certain volume and capacity. So if we normally do bladder tracking, so we say what kind of fluids are going in, including diet if we need to, what's going in, and then what's coming out, how much is coming out, and how frequently is that said fluid coming out. Typical rule of thumb would be that we want them to be relatively even with less on the side of output, right? Because we're absorbing and we're utilizing fluid. So
Hmm.
some people, and I don't know where you're at with fluid intake, some people drink a lot. They drink a
Hmm.
lot of water or other fluid sources. And so they're going to pee more. Like there's a normal
Hmm.
volume. If that bladder is full and you really have to empty and you drank that much fluid, that makes sense. It's a normal We just say, do you really need it all? Why are we drinking that much? What's going on? There can be some medical issues, some diabetes, et cetera, that we might look at, like why your body's getting rid of a lot of fluid. So there's certain things in that category. However, if you've ever drank a glass of coffee and felt like you need to pee shortly after, or poop, that happens too. Normally it's from the warm though, not the caffeine. There's something related to caffeine that can increase the frequency in your body. So if you're an energy drink drinker or somebody who intakes caffeine, there's also some other top hitters in there, including carbonation for some people or citrus. So like think fruit juices with like vitamin C or citrus in them. Could even be V8s, tomatoes also. Those can also make your urgency go up. The other side would be if you're not drinking very many fluids and you're low on that. It's like, I like the example of soup. So if you're making a pot of soup and you accidentally made that soup too salty, what do you do to make it less salty?
Yeah, add water.
You add water. So if you're dehydrated in a sense and you're not intaking enough absorbable fluids, so caffeine doesn't count because it flushes you, it's a diuretic, so water, etc. If you're not intaking enough of that, then your bladder says, I don't like this feeling, and it wants to give you this strong sense of urgency to pee when really not that much is coming out. And so most people come in, they say, I pee a lot, but it's not that much when that's happening. I pee frequently, but it's not much. Yeah.
Okay. Why is it that when you drink iced tea, you have to pee so much more than when you drink water? Is this because of the caffeine that's in the iced tea? Okay.
Typically. Yeah. Unless you just gulped it down all at once, in which case a lot's going to come through at one time,
Yeah, for
which would happen
sure.
with water too. But yes, it's the caffeine. Yeah.
Okay. So if somebody is like, okay, this is starting to just be annoying, is there a test that they have to do? I'm assuming, like, or you just have them track it throughout the day?
It's normally symptom tracking. Obviously, if there's something that's not matching in that, we might have them go in to do some bladder testing, which they would put a scope up there, check the bladder out, do some different tests to make sure. That'd be through your urologist, not through my office. But that can happen, especially if there's a pain dysfunction or something else going on. But yeah, most people, run-of-the-mill people, don't tend to have that. Normally they have pain and they have some other bigger issue going on. But people say, I just have a tiny bladder. I'm like, do you really? You might, but it might just be also nervous system looping that's teaching you that's the patterning you need. So,
Is there a way to train yourself to be able to hold it longer?
yes, as long as it's not
Okay.
truly like a capacity issue where you
Right.
drink tons
Okay.
and it's just full.
hmm
But yes, totally is. We do it all the time. Yeah.
So this is some like Mr. Miyagi shit. So how do you wax on, wax off with us, Sarah? So is it
I'm going to
just
give you a simple thing,
yeah,
super
give us a
simple.
simple trick.
It's more complex than this is, but it'll give you an idea. So,
Okay.
your bladder is controlled, or the urge sensor is controlled by a part of your brain you don't have access to.
Oh.
So you have control to say, I'm going on a trip, I'm going to go sit down and pee. You have that control. But your urge sensation is not, you're like, I'm choosing to have the feeling of needing to pee. No, your body's just
Mhm.
doing it for you. So we have to trick the body by accessing that. And there's, I'll say, four simple tricks that we start with just to see how the impact is. The first one is the most bothersome for people, and that is never rush to the bathroom. Every time you rush with that sense of strong urgency, it's telling your brain, oh, I want more of that. It's effective. It's getting the result that I want, which is
Mm.
emptying. So rushing actually over time makes that worse. So that'd be
Okay.
number one. It doesn't mean don't go, it just means don't rush. Okay. The next three are to try to get that urgency under control. So one would be distracting yourself. These sound so silly, but they're really effective. So distracting yourself, think about something different, change activities. If you're washing dishes and the water's stimulating, turn the water off, those types of things. Another is going to be about 5 to 6 nice, deep, calm, relaxed breaths that stimulates the parasympathetic system, vagus nerve work. It also, because of breathing, moves that pelvic floor, and the pelvic floor movement helps stimulate the bladder and kind of calm it down. So breathing. And then the third, which is optional depending on pelvic floor function, would be pelvic floor contractions, and the same number, like 5 to 6, because that pelvic floor movement stimulates that bladder and can kind of turn off that signaling for a while. So those are
Okay.
like some simple steps that I have people take to start with for
Okay.
getting that urge to go down.
Anyone else a frequent peer here? Or is it just me? Frequent peers anonymous here. Okay,
There's
Lisa
many
says, yeah,
people, not
me.
just you. Yeah, very common.
Okay, very interesting. Great tips. I mean, obviously, distracting yourself is, it's like when it's because my son has said that to me before, and he said it to my daughter. He's like, just don't think about it. And I'm like,
Yep.
okay, how do you just not think about it? It's like, you can't not. He's like, no, you can't try it. And I was
You can,
like,
yeah.
oh,
Yeah, it's a very effective method. And we couple that obviously with other things to try to help support that over a long term. But that's kind of a starting point.
yeah, yeah, makes perfect sense. I mean, yeah, you're not putting it at the forefront of your brain, and then you're just like thinking about
Mhm.
your grocery list or something, I
Yeah,
guess.
and that urge will come back. Doesn't take away forever, right? It's a
Yeah.
normal urge patterning, but getting your body past that intensity to let your body have time to go is the first step.
It's
Yeah.
kind of like training. It's like reps. You're putting the reps
Yep,
in.
exactly.
Putting
It's
you're
high
putting the
reps.
mental reps in. High, oh
Yep.
gosh, yes, high reps for sure. Okay, I love that. Now, let's talk about the peeing when we sneeze, when we
Mm,
jump rope, maybe because we're like trying not to rush
mm,
to the bathroom to pee, but we got to pee and there's like, there's a dribble situation.
mhm.
Is this usually linked to like pregnancy and giving birth, or do you see it just across?
Yeah,
Okay.
I
Yeah.
see it across the board. So there's, can I differentiate a couple things to separate in
Yeah,
people's minds? Okay,
absolutely.
so we've got this urge piece we talked about, which is the rushing to need a pee and then dribbling on the way. That's a totally different mechanism of leakage than jumping, sneezing, lifting leakage. So
Mm,
one's called urge urinary incontinence, which is that I can't hold it, so I'm peeing on the way. Totally different mechanism, treated totally differently. Sometimes they do happen together. And then the other is called stress urinary incontinence. So that
mm,
stress incontinence is the I'm jumping on a trampoline, I'm doing a lift, whatever that is, and you're having
mm,
leakage during the activity. The treatment mechanism is quite different
mm.
within each one, but within the stress incontinence, that jumping, lifting, exercise kind of induced more one. There's also two very different treatment mechanisms within that, depending on how you're presenting. So one could be there's weakness there. We don't have a lot of management of pressure. I have a couple case examples that I just made up if you want some of those just for a more practical application.
Yeah, sure.
So I'll give you those in a minute. And then the other side would be there's actually too much tension in that pelvic floor. And so it's not able to absorb the forces correctly. Let me give you
Oh,
an analogy. It might make more
okay.
sense.
Yeah,
First, I got my little pelvic model so we all know what we're talking about because we love that. So just for
love it.
visualize for those who are on the call. So the pelvic floor is a hammock or sling shaped muscle group. That sling shaped muscle group, I want you to visualize as a trampoline. This is not a perfect analogy. It just gets you kind of grasping some concepts. So if you've ever been on a trampoline, we've got the good ones that have nice mesh that's not too firm, but not too saggy. So think about a pelvic floor. If we're too tight, it's not going to be springy enough. It's not going to be as fun to jump on. And if it's old and it starts to have holes and rips, it's not going to hold well. So you're going to have some dysfunctions the other way. You might fall out the bottom of it, right?
Mm,
The springs of that trampoline are kind of where the anchor points are of the pelvic floor. So again, you want a good amount of spring, but you don't want the springs too tight, and you also don't want the springs too loose. So there's a nice balance. The base of the trampoline and the legs are more like the bony structure, so the pelvis itself, the hips, etc. And then if you have a fancy new trampoline with the mesh kind of safety don't fly off walls, which I never had as a child, those mesh walls are kind of like the what people think of as their core, which the core is really this whole system that we're talking about. It really works together. So that's kind of the overall functional movement of that mechanism. So then when we're
mm,
talking about leakage related to tension or weakness on the other side, the looseness with that leakage component, hopefully that trampoline will make a little bit more sense when we're talking about that. So
mhm,
if we're too tight, too much tension, some signs of that could be you have pain with penetration, or you have in the past, or you currently do, whether with
mm,
sex or exam or tampon insertion or whatever, there's some tightness that's there. It could also be that you say, I always run, I'm not flexible. I've always been tight my whole life. I run really tense in my body. Those are
mm,
symptoms that often match, not always, with increased tension in that space. The opposite side would be people who are really bendy, hypermobile, lots of mobility, hard to control. That's myself. Just lots of movement also tends to run tight in the pelvic floor because it's
mm.
trying to create stability.
Okay.
Okay. So when we have tension, the trampoline analogy, that pelvic floor doesn't have the rebound ability to be able to absorb. It's like jumping off of something with your legs straight versus
Oh,
jumping with your knees bent, right?
mhm,
So if you jumped off of something with your legs straight, it'd be more likely to have an injury or pee. Okay, so something is bound to leak through. And if you bend your knees and it's nice and absorbed, it has that rebound, that shock absorption.
gotcha.
If you are too loose or too weak, then when you're jumping off of said trampoline or whatever you're doing, you don't have the integrity to be able to actually withstand the forces. So it's just hard to lift. So that mechanism normally makes more sense to people. Oh, I'm just not
Mhm,
strong enough to hold it. But the opposite one is actually really common. And we see it outside of pregnancy. We see it in teenagers. We see it in people who are 40 who have never had a child. And we also see it in people who've had children. So pretty common.
Okay. What do you find that there's a common reason, one way or another, that people are
Mm.
experiencing these issues? In your
Other, yeah.
experience, at least.
Other than the
Yeah.
obvious, I've always run tight or the hypermobility, which we chatted about. The other one that I see pretty strongly correlated, which does match up with those, is people who have really poor balance in their nervous system. And I don't know how far into the weeds this way you want me to go, which isn't pelvic floor specific,
Well,
but it's
no,
really
but I find
overlapping.
it
Yeah.
fascinating because, you'll have things that medically from just obviously what you've learned, and then just from what you see, you start to see, yeah,
Yeah.
yeah, for
Yeah.
sure.
So that pelvic, the nervous system piece, if you've heard about vagus nerve, a lot of people have. It's a very popular thing to talk about these days. But the vagus nerve is part of the parasympathetic system, which is your like rest, digest, calm system. And
Hmm.
then your fight, flight, stress response, which we all have underlying stress. So we all have a stress response. Some of us it's too high. That system tends to take over if we don't have good balance. So it's like two dials that we want to be relatively balanced, but one's like way turned down and one's way turned up. So we need to try to create a balance. And the pelvic floor is a unique muscle group. It's skeletal muscle, just like your bicep, your quad, etc. However, the difference is still innervated. You can still contract, relax, just like your bicep, but it's innervated by the autonomic nervous system, which is part of that sympathetic, parasympathetic, unconscious controls your blood pressure, your breathing rate, your digestive system, etc., and also pelvic floor function in some ways. So it's very a unique grouping. And because of that, nervous system overlap is pretty strong in that area.
Hey, I know you are knuckle deep in this podcast episode right now, but I am here to just let you know that if you aren't on my newsletter list, this is where you want to be. This is where I will be sharing more behind the scenes content of some things that I'm working on, some projects. If you're interested in any of the retreats or workshops that I'm going to be hosting coming up in 2026 and beyond, you're going to want to be on the newsletter list. Listen, I know email's archaic. I know we hate being in there. I know it's scary, but you can do it. We can do this together because the emails you get from me are not going to be the shit spam emails that you get from everyone else. All right. I'm talking about real stuff that's useful for you in real time, that you can reference, stuff that's going to jog your brain a little bit, make you think about life, not just another influencer who's just spitting a new workout and a meal plan at you. Plus, anytime I create any fun freebies, any actionable tools, steps, or strategies, my newsletter people are the first to get it, and you won't want to miss out, especially for retreats and workshops that are coming up, because this is the shit that makes you the boss bitch that I know that you are dying to be in your life. All right, go check out that link. Okay. Wow. Interesting. I love geeking out on this stuff. I was like, I knew
Love
you
it.
were going to come in with all the goodies. Now, when it comes to the case of, I pee my pants when I jump and that sort of
Mhm.
thing, do you give people at home exercises? Is there generally like treatment that comes along with that? Because I'm assuming that it's a very vulnerable thing for women to have an exam around or talk about with
Mhm.
their doctors, unfortunately. But when it comes to a specialist such as yourself,
Mhm.
I'm assuming, are there like certain tests that you usually run people through? I'm very
Yeah.
curious, like how that whole process works.
Yeah. So if I'm seeing somebody in person, it's a little different than virtually. So I do
Mm-hmm.
both ways. So in person, gold standard care in person is always the best, but virtual is great too if you don't have access. In person care is one, we just find out what's going on, get a history first. But if someone's okay with it, never forced, we do a pelvic exam. And that
Mm-hmm.
pelvic exam is external, but also internal because we need to access the muscles that are potentially causing dysfunction. So part of that is we do muscle strength testing, which I'm not going to go into explaining how that all happens because it's confusing because it's all inside your body. But we test the strength of the muscle. We test the fast twitch fiber. So think like if you were to jump or reach out to grab something really quick with that's a fast motion. You have the same fibers in your pelvic floor to absorb force. We check for that. We check for endurance. We do all of it. We check for muscle tender points, how everything feels, etc. And we're checking this whole basin, everything inside there. So that would be the internal component of exam, but that's not
Mm-hmm.
all because your body is very wrapped up. It's everything, right? So I'm also looking at how's your core function? What's core meaning what people think of as more abdominally? What's your breathing look like? What's your rib cage position? How's your diaphragm? Do you have like a really flattened diaphragm given your posturing? You're not going to have great movement of that pelvic floor because of that. Your pressure management might be really off. What's going on? It's easiest if it's just weakness.
Mm-hmm.
So if you're coordinated well, relatively speaking, and you just are not very strong, that's the the easiest way to go. But it's very rarely the case. Most people have some sort of very poor way that their body coordinates together, or this tensioning pain component that makes it that much more complex on top of it. I don't know if I fully answered your question, but hopefully I did.
Yeah, yeah. And I think really thinking more along the lines like, do you think women are misled with information out there? Like, oh, just do some Kegels and like,
100%.
okay.
Yeah. There is the influencer wave in the pelvic floor sphere, which is newish. I mean, in the last 5, 10 years maximum, but more 5 years, where there's all sorts of people giving pelvic floor advice. Take my workout program for postpartum, do this. Like there's
Yeah.
and very few of them have any input from an actual pelvic floor specialist. And even fewer of them are actually pelvic floor, like actually have certifications or something in that sphere.
Mm-hmm.
So that being said, take things with a grain of salt. They do
Yeah.
help some people. They may not fix things fully, and they may make symptoms significantly worse depending on
Hmm.
what's going on in your body. So, for example, if you are somebody that runs with tension, you may not know you do, and you start doing more Kegel based exercises, your symptoms are going to get worse. They're not going to get better. And you're going to say,
Mm-hmm.
what the heck's going on? I've done all this stuff. I'm failing. I don't know what to do. And many providers have no idea how to treat you. They think we'll give you some medications and here's some things. But the
Mm-hmm.
true issue is really you have a spasmed up muscle and they're causing a lot of dysfunction. So that would be the extreme end. But then the middle end is you're really perpetually training yourself in very poor motor patterning. And so
Mm-hmm.
if you wanted to push in training into something else, you may get an injury or have symptoms return or whatever's going on because you really didn't fix it. You just kind of did some stuff that helped temporarily, but didn't move you down the road far enough. So there's my
Yeah.
two
Wow.
cents on the
So
influencer
crazy.
sphere. Yeah.
I mean, do you ever like give people a way to be able to discern one way or another on their own, like to test
Yeah.
themselves?
So like
Like, oh,
virtually. Yeah.
mm-hmm.
So when I'm treating virtually, I have, depending on people's comfort, not everyone is comfortable doing self pelvic exams. You'd be
Mm-hmm.
surprised that many people are not, even if it's their own body. It surprises me actually. So I'm like, why not? But not everybody is, which is totally fine. So I just you normally figure it out by symptom based. So you can just see how their body moves. I watch them do movements. I have them move around on their screen, et cetera, and kind of cue them on what to do. If they're not comfortable internally doing an exam, I have them do an external. There's an external way to kind of at least do a screening idea, it's hard to explain fully on here without showing you. But yeah, so I have some patients do internal screens too, but it's tricky if you don't know what you're looking for, it's
Mm-hmm.
hard to test yourself. That's the hard thing. Or if you don't have somebody explaining it to you fully on how to do so,
Right.
it's very difficult to do a self test.
Mm-hmm.
Yeah. So that's why we have people like myself or other providers that do them. It's just
Yeah, I
tricky.
imagine.
Mm-hmm.
Yes, an interesting, yeah, trying to figure that out. Now, do you see that women have injuries or something that they probably think is not even related to pelvic floor? Like, is there
Mm.
something that comes up for you and you're like, oh no, that's totally pelvic floor, and people are just walking around absent-minded, not realizing, and they're thinking it's something else? Does that make sense?
Yeah, there's a lot of things that overlap because, of course, that pelvic floor is a pivotal part of core function, but I
Mm-hmm.
won't go into that because it's a little bit more, it's not as obvious. The first one that popped in my head outside of that is tailbone. So tailbone pain or tailbone injury,
Mm-hmm.
always correlated with pelvic floor.
Really?
Always. Yeah. So whether it's that you get kind of sore or sensitive with exercise, or if it's
Mm-hmm.
more with sitting, or if it's both, whatever the sensation is, there's normally a pain component or a tenderness component. So that's 100% normally associated with pelvic floor, just because that's
Mm-hmm.
where muscles anchor to. The other, which I think most people associate with pelvic floor, but not all, would be the idea of prolapse. So pelvic prolapse symptomology.
Mm.
So people
Okay.
think it's just like my uterus is falling out or whatever the horrible terms people have been told by their
Right.
providers. That's an organ system technically, but there's a very strong pelvic floor influence in that space. Yeah.
I mean, that seems like that would make perfect sense. Do you find that C-section affects pelvic floor more
Mm-hmm.
than it doesn't for women who give vaginal birth?
No, that's actually a really interesting question. More interesting than you know. So I won't go too deep into that. But a lot of people think I won't have pelvic floor dysfunction because I gave birth through C-section.
Yeah.
And that's not the case because one, you can have pelvic floor dysfunction with no birth. However, birth is a risk factor for pelvic dysfunction. We know that.
Hmm.
But just pregnancy itself is a risk factor for pelvic floor dysfunction because of the massive and rapid change in weight and pressure and how your body and posture changes. So C-section folks can have still pelvic floor dysfunction. They're less likely to have vaginal tearing and those types of things that can lead to
Hmm.
dysfunction. But some people C-section after trying to deliver vaginally, so they can have both.
Hmm.
So it really, no, it's not exclusive one or the other. And you can actually end up with some pretty significant core dysfunction because of C-section scarring if you don't know how to actually achieve mobility in that space. So people end up with the mommy shelf, as they call it, like that tummy that
Yeah.
just doesn't go away. They've got all the scar tissue that's not working well. So we as pelvic floor PTs do a lot of abdominal scar work, whether that's bowel surgeries or whatever surgeries. It could be C-section too, not just pregnancy related. Lots of scar work or things like endometriosis with heavy
Hmm.
scarring too. So a great space in the pelvic floor PT world for treatment there.
Okay. Yeah, I always wondered that. I didn't have C-section, but I was curious because I mean, they're cutting through layers of, muscle tissue, abdominal
There's
wall, all that.
eight layers. It's a
Oh,
lot. And each one has
wow.
to be surgically sewn up. It's a lot.
Yeah.
Yeah.
Wow.
Yeah.
That's, yeah, interesting. What's your favorite sort of transformation that you do in your work if you
Mm.
had to choose one where you see someone come in with this particular issue and you're like, yes, I know the 1, 2, 3 trick on that. And then they have like this massive
That's a
sort of
good one.
result.
The one that's the quickest typically, because obviously a lot of people are like, you gave me I have a card literally on my desk with somebody who was like, you changed my life. I never thought I'm like, this is why I do what I do. It's
Mm,
amazing. But if somebody wants to come in and leave on that same session and say, this has changed and it doesn't go back and it typically stays, scar work. Scar tissue
mm,
release is powerful and it is pretty obvious right away what's changed visibly, visually, or symptom wise. So that could be an old scar. Maybe you're like, ever since I had a baby, I have pain with sex in certain positions, not always. You never had pelvic floor PT. There could be some scar tissue from a tear or an episiotomy or whatever is going on there. You do some release on that, and you're like, it's gone. This is amazing. It's normally gone between and around 3 visits, treatment. It's amazing. It's so great.
wow.
The same is true on C-section scarring, depending on how sensitive it is, right? If it's early on and hypersensitive, then that takes a little longer. But scar work is really powerful and it's really noticeably different. I have taken people from 1 to 2 sessions from basically having no lower abdominal engagement. We release the
Mhm.
scar and all of a sudden they can kick it on. It's so great.
So does that involve like self massage? Is that
Yeah,
usually okay?
yeah, some, but I do a lot of manual work that's more advanced than what people could do at home. But I always give them something that they could do that's simple. Our hands as PTs, especially in the pelvic, the people who do a lot of manual therapy are like, we've trained our nervous systems to feel things that other people can't feel. It's just hard to explain, I guess.
Mhm.
But the analogy that a professor gave me in school, which is just blows my mind, which is true now that I'm here, is we pull out a hair and we put it on the table in whatever shape with our lab partner, and they put a piece of paper over top of it, and we had to find the hair and trace the hair. And people were like, "Oh, that's amazing." And we're like, "Yes," but then we had to add another piece of paper, and then we had to try again. And our instructor could do 6 sheets and find a hair
Wow.
underneath. So the amount of feeling that we have for so scarring, etc., it's definitely a learned art, but you can
Hmm.
do a lot on your own too. So we teach a lot of home programs for that.
Incredible. That's
Yeah,
amazing. I love that. Let's talk about sex.
love it. It's one of my favorite topics.
Let's talk about sex on the pelvic floor.
Hmm.
What do you have? Do you find that women come in like, let's just talk about maybe like whatever your favorite topics are, of course, but I'm thinking more along the lines of like maybe women who have trouble orgasming or,
Oh, I love that topic. Yeah,
yeah, yeah.
so great.
Hmm.
So let's put the caveat out there that when I'm talking about this, I'm not talking about someone who doesn't know how to orgasm, meaning they don't have the skill.
Gotcha.
Okay. So that's a
Hmm.
totally separate issue. I mean, it may not be separate, but it may just be that they just have never tried. Okay. They don't have the techniques, which is definitely a thing. And we work with people, I've worked with many people from very conservative backgrounds that had no exposure and were having no pleasure. So there's some website resources I can give people that are nice and not like, there's lots of resources out there. So that's a side point,
Keeping it PC. Yes.
keeping it PC. So and a lot of people are like, I don't want to look at anything. It makes me uncomfortable. So there's lots of options for viewing depending on people's comfort level to give education to themselves and their partners. Okay. So that's
Hmm.
case in point number one. Also fun, even if you're not shy about things and amazing resources. So outside of that, let's say you came to me and you said, ever since for the past 5 to 10 years, I used to be able to have great orgasms, but they've just been getting less intense. Like I still have them, they're just not as good anymore. And I would ask
Mm-hmm.
questions like, okay, is your partner the same? Have you know those questions? You know, everything else is the same, but I'm not having as much success or just doesn't feel as good. Okay. Question number one, based on your age, I would say, have you had your hormones looked at? Are you doing anything to help support the tissue? Are you doing any type of localized estrogen therapy, which is extremely well tolerated and very effective in helping reduce dryness, any type of pain, even if there's no pain present. It can plump the tissue. It can help with atrophy. It can help with leakage reduction. I'm like, that is your first. If you have not done that, let's start there. Okay.
Mm-hmm.
Number one. There's also vaginal moisturizers. I have a little sample pack here, this is the Good Clean Love moisturizing vaginal gel. It's great for people with dryness and sensitivity. So got all sorts
Mm-hmm.
of little tricks there. Try some lubricant because sometimes friction is it's just not jiving how it used to because you're not making as much. That's possible.
Mm-hmm.
But from a pelvic floor perspective, first let's talk about how an orgasm works. But let me not assume that everybody knows how an orgasm works. So you have something called a clitoris, just in case you didn't know. And that clitoris is not just the nub that you see on the outside. That is a very small component of the clitoris. It's tiny.
You don't have a vag puppet? I'm so surprised.
I know. I don't have one with me right now. It's so terrible.
Put that on your Christmas list.
I know. I need to put that on there. So the clitoris is not this tiny little pea-shaped thing or whatever everybody's size varies. Okay. So it's not just this tiny little thing. It's actually really massive. Women are amazing. Men don't have this. They are not lucky. We have a massive sexual organ, which is great. And so when we're thinking about the clitoris, we also need to consider, and okay, I know this is going to podcast, but I'm going to pull my model up just for those visualizing here.
Yeah.
We need to consider the muscles in what we call the urogenital triangle, which is this front kind of grouping of muscles. If these muscles, which are one of the primary functions of sexual function, they contract, retain blood, and help with arousal and orgasming.
Mm-hmm.
Okay, that's the first piece. So if these contract appropriately and you have good flow and good movement, you're going to become sexually aroused more so. Your clitoris, you're going to have the swelling, you're going to have all that stuff that takes place before that orgasm comes on. So that's a really important part of that. If these muscles are not working well, it's not going to be as good. You're going to have a harder time getting there. It might not be as strong, etc. The other part of that orgasm is not just setting it up for success here. I'm going to pull this piece off, but this levator ani group, this hammock-shaped muscle group, you can see it here and you can see it from the inside in that space. This muscle grouping does a lifting and kind of pulsing during orgasm. So that's muscular. A lot of people don't realize it's your muscles moving, and it is. So those muscles need to be able to contract, relax at whatever speed is necessary given the type of orgasm, the intensity, etc. And if you have dysfunction in those muscles, think my muscles are more atrophied because my hormones have shifted, or I've gotten really weak. We don't normally see a ton of atrophy in people who are pretty active, like overall pretty healthy individuals. We normally see that in really old, like inactive people. I don't work much with that population at this juncture in time. We see a lot of inactivity. Many are not sexually active by that point anyways, so it's not their primary goal. Digress, back to sex. So with that pumping motion of the muscles, we want good strength in the muscle. Stronger, appropriate strength in the muscle is going to increase your orgasm intensity, or can. Well, many factors with orgasming, obviously. And then the other is going to be the ability to actually drop down. So if you can't relax, so you run with higher tension, you may contract up, but then you have this mini range of motion. Does that make sense? So you have this like small pulsing at the top versus big pulsing up and down, which is going to be more intense. The other would be true not true, but the other side of that would be if you're really weak, you're going to get also a baby sensation just with no lift from the bottom. So there's two extremes where that could be less intense with just weakness or increased tightness. With the weakness side, if there's a hormone relation, estrogen therapy can be really helpful as an adjunct to pelvic floor PT. And if it's a tension side, sometimes estrogen therapy can still be helpful if there's other components for maybe there's pain in your guarding, etc. That can help as an adjunct to pelvic floor PT also. Many are not as effective standalone, but I've seen some people who have come to see me like, I'm pretty good, but I just want some help with orgasming. And I'm like, sweet, you're great. You're awesome. So we just look and we just say, what can we do? What kind of dysfunction do we see? I can't guarantee that orgasm will be better. There's a lot of factors at play. Partner, arousal level, many technique, etc. And I'm not a sex therapist. I'm not a sex therapist. So obviously we go over some things and I just say, that's a little bit beyond me. So let me just send you somebody. I got my gal. So I'm like, go see her. So that's kind of what we chat about, if that's helpful. That's kind of the orgasm mindset. And so if you have increased weakness through time, strengthening is normally very appropriate to make those orgasms better if you have achieved them in the past. If you have never achieved an orgasm, it might be a different ballpark. We're probably looking at more of a tension issue. Yeah, there's some other things too, but tension's pretty common for people who really struggle or have never had one, even though they've tried. They've really struggled to have one. Yeah.
Yeah. Yeah, that makes sense. Any questions from the peanut gallery? Feel free to chime in the chat for sure. While we have Sarah here, this is the time not to be shy. What are you most excited about right now in your field of practice?
Well, I'll tell you one of the courses I just signed up for, which I haven't taken yet. But what I'm really excited about right now is learning about the really subtle, I shouldn't say really subtle. It feels subtle. It's just not as obvious. The less obvious movement patternings in the body and how we can sort of trick our body to do what we want by these really unique exercises, right? So they're not traditional exercises and movements. So it'd be like, what if I lay on my back and put my feet on the wall, but shift 1 foot higher, squeeze a ball and blow a balloon? What is that doing for me? Right. So there's some really unique patterning that can really train things to load in the right way without making it too complex in your mind. You just say, can I get in this position and do this thing? And then my body's doing what it needs to do versus thinking contract here, pull here. It just gets a little too overwhelming for people instead of giving them a movement pattern. And they're very unique. They're not things that I just like, off the top of my head, I'll just pop that out. Right. So some really unique stuff that can make treatment easier from a virtual standpoint, which is great because we can access things without me touching. Right. So it gives that feedback tool, but also for people who just really like having stuff to do at home or, more access to that and just easier in clinic also. So really excited about that. It's kind of geeky, but I'm into it.
No, it makes sense because you're working from a virtual space, which poses its own set of challenges, especially with this being such a hands-on type of practice. So you got to use all the tools in your toolbox. I understand that. What do you have, if any, like your own go-to daily pelvic floor practices, if you will? Is there something that you do on the daily that you just kind of always make sure is in check?
There's one thing right now I'm doing on the daily, but there's many things. There's some things that I do when I feel certain symptoms creep up. So I have I don't know if that's a daily, but it's kind of a routine. So for me, being a hypermobile, bendy person, I tend to run with a little bit more tension. My body wants to almost brace there to try to create stability. I find myself often during the day saying, I just need to relax back down. I'm holding and I don't need to hold. So I just relax. And that could be muscles around the pelvic floor. So key ones are belly bracing. If you're holding your tummy in, belly bracing, squeezing your glutes, which people do all the time without paying attention to it. Really common. Yep. Glute squeezes. It could be those groin or adductor muscles. So if you're a lady and you cross your legs, but then you kind of squeeze a little extra hard, that's pretty common too, versus just a really relaxed leg cross, or your knees are held together, which is just terrible that we as women have been taught to do that. Just hold and just contract those muscles constantly versus letting them sit at a more neutral pelvic positioning. So that's another one for gripping, breath holding, those types of things. So if I find myself doing that, I say, oop, just let it go. I don't need to hold it. Just sets myself up for more tension, just release and let it go. If I am, because none of us have perfect bodies. So I am also postpartum plus 2 kids, etc., and need more time to myself. So there's that. But if I'm going to be doing some jumping, which I do pretty good, but if I do a little bit more than a few reps of jumping, because I just don't jump very often, I need to do a pelvic floor brace. I need to turn it on carefully. I need to make sure I'm managing my pressure well and do more that way versus just not thinking about it, because it just doesn't set me up for success. And so that's something I do if I'm going to do it in that situation. The other piece is practicing good rib cage positioning to help with my breath and my diaphragm movement. So this one, I can totally geek out on this, so I'm going to have to simplify because it is so cool. But your rib cage movement, a lot of people think that if you sit up really straight and you kind of stick your chest out really far and think, oh, I have great posture, but you're actually overextended in your thoracic spine, your upper back. It flares your ribs out in the front, right? Which actually flattens your diaphragm, locks out your back, and it sets you up with, from a breathing pattern wise, to actually increase tension. Or if you're really weak, just increase a ton of pressure downwards. So instead, we need to teach the thoracic spine, that upper back, how to fall into its natural kyphotic curve. I know I'm using fancy terms here, but it's kind of it's not slumped posturing. It's just this natural curvature that it tends to have. And people often think, well, if I'm there, then my shoulders are so curled forward, then my posture is bad. And I think, no, you just have really weak scapular control. We just need to actually strengthen your shoulders and bring them back without having you feel like you need to be like this because gravity helps hold them there, this forward chest position. So rib cage function, which is coupled with thoracic spine mobility and diaphragm function, is really pivotal to pelvic floor function, especially if you have any type of symptomology. Yeah, I could get on my highest horse about that for a long time with any type of weight work, anything, literally anything. That posture piece is really significant. Yeah.
Yeah. When you talk about the bracing before jumping,
Mm-hmm.
I guess I don't realize I'm doing that before
Yeah.
I go into jumping because right now in the phase of training we're in, I introduce some jumping and some jump rope
Mm-hmm.
into the program because as women over 40, it's great for us to be pushing our body up against that sort of force
Mm-hmm.
for bone and all that great
Yeah.
stuff. And so I was obsessed with jump rope for some years and I'm like, okay, we're bringing this back in. And I had a little moment where I'm like, ooh, I'm
Yeah.
going to pee myself. And so then I just had to be really conscious of that every time. And so I noticed that I'm doing this sort of little checkpoint
Kind of brace. Yeah.
situation.
Which is great.
And I start slow. Like I just kind of don't even bring my toes off the floor at first to just make sure I'm braced and ready to go. And
Mm-hmm.
then we go. But yeah, it's a common theme. I mean, when we used to do that at the studio, girls were like, I peed my pants.
Yeah. Yeah. If that's happening to you, one, if you can do a self correction and it goes away, amazing. It might just be a coordination thing, right? Just kind of wake things back up and tell it how to brace. It's just fatiguing and you're doing a natural kind of strength program and it's doing what it's supposed to. But if it's not hanging on well and you can't control it well, there's probably a bigger dysfunction happening. So getting some help is pretty significant. The pelvic floor is 70% slow twitch muscle fibers, which basically means that that 70% of those fibers are on all the time. They don't ever turn off. They just have a different degree of onness.
Okay.
So it's interesting because we want to teach the automaticity, like the automaticness of pelvic floor function. So when you're talking about jumping, you're like, oh, I didn't even realize it was kind of kicking on for me. And then all of a sudden, oh, shoot, now I need to kind of be intentional about that activation. We want it to be automatic as much as we can. But before it can be automatic, we have to teach it how to actually do what it needs to do. So there's a conscious volitional contraction and there's the automatic, which is our goal, is to get you to that part. And so it's very different types of training when we do that to try to turn that piece on automatically.
Gotcha.
Kind of cool.
Do you think that women who train tend to have issues more one way or another in terms of being either more loose or lax, or is it really just individual? Because I'm thinking weight training, does that add to having a tighter versus looser pelvic floor, or is that not even relative?
I think it's more, which I think in general, people who do exercise weight work have less dysfunction in general. However, if you already had something going on and you're doing more weight work, you're going to just go to farther extreme of what that is. It's not going to necessarily cause something. So if you already run with more tension, you do a lot, don't regulate well, you're going to have more tension symptomology. And if you're already kind of weak, even just a little bit, you're doing more, not bracing well or controlling that, you're going to have more of a leakage issue. So I don't think it causes that. I think you already are just there and then it just perpetuates it if you're not treating it effectively. But in general, I think weight work, exercise in general is fabulous for our overall health, especially as women. So a huge advocate. I'm like, lift heavy things, do it safely, do it, with a mindfulness, look up some videos and look at some form. It's going to be probably better than yours if you haven't done any. Like get some, even if it's not perfect, start lifting something because that's so key. And our pelvic floor needs that. It needs that load. So
yeah, absolutely. Do you find there's any correlation with low back pain ever? Like, do you find that? Okay.
Huge correlation.
Okay.
Yeah.
Super curious
back,
about
hips,
that.
Abdominal, diaphragm sometimes. So people who get pain come up underneath their rib cage. Obviously mentioned tailbone. Any type of pelvic girdle pain, which is like into the bony structure. So SI joint, pubic symphysis pain in the front. All that can be pelvic floor related. Yeah.
Oh, wow.
Doesn't mean that it is because you can have an isolated hip injury or you can have an isolated low back injury. But over time, they tend to all mesh together anyways because we start to compensate and move differently. So it depends on how acute it is and how old and chronic it is. We just get more spillover. The longer it's been there, we get more stuff involved. Yeah.
Okay. So I'm assuming if someone comes to you for a consultation, you just kind of run them through the gamut to see if there's, okay.
We do, because I don't know, other than the brief call we have, I know literally nothing even about how they look and how they move. So I just say, we're going to have a video call. I need to be able to see you, the whites of your eyes, and then farther away, I need to see your body. So I need to see the movement of that and just we do a lot of questions. We get a lot of information by how people's bodies are responding to things. And if they have no idea, which is really common, people don't pay attention to themselves. We just have them log it. We just say, I can't, I just need to know what your body's doing. So you need to log your
Mm-hmm.
pee, you need to log whatever we need to do. We need to see what's happening. So
Yeah.
that's the same
Yeah.
in person or not, though, that part.
So
Yeah.
interesting. Well, we're coming up on an hour and I want to be respectful of your time, but I have one last question and then maybe you
Okay.
can share with us, how if somebody wants to work with you or they can find your information. What do you wish more women knew?
Ooh, that's such a big question. I wish more women knew that pelvic floor therapy in general is not scary. I think there's a lot of people who don't start because they think it's going to be weird or they think, oh, it'll just go away or, whatever. It really, they get scared because of hype or things that they've heard about. And that may not be their experience at all, especially if they're seeing someone who truly is treated like that's, this is all I see versus somebody who just does a little bit and dabbles. So that would be the one caveat there. See somebody who truly specializes. They're never going to force you to do something you're not comfortable with. They're always going to have your best interest in mind. They're normally, not that I toot my own horn, but very personable people who they don't love what they do. They're not going to be specialized in it. They're not going to be doing it. Right.
Yeah.
So it's okay to see someone. It's okay just to go one time and to say, I just want some information. I'm not ready to start yet. I'm a little nervous, but can I just get some information so I can start applying things? There's nothing wrong with that. It's okay to end if you're like, oh, my life is just crazy right now. I've gotten some tools. Let me do this and I can restart later. And like, it's okay. Great if you can just power through and do a bunch. Also great. There's no bad time. I think there's just a big fear of people to get started and they're worried about what that's going to look like. Or I think I won't be able to exercise. It's all going to be my pelvic floor. Not if you're seeing somebody who knows how to treat the body as a whole. It's going to be working with your lifting. It's going to be working with run. It's going to be doing what you want while applying pelvic floor to that. So I
And
never say
probably
never.
improving that. Yeah.
Exactly. Yeah. I never say,
sure.
oh, you'll never run again, or you'll never, if you have a provider that's saying that to you, that's fear mongering. That's not accurate. And we need to have a conversation about why, or it's just say, here's the risk factors. It might be, ooh, not ideal, but here's the risk. And that's your choice. It's your body. You get to choose. So that's the biggest thing I see is just this fear of starting. So,
yeah.
yeah.
And you're so like I said in the beginning of the call, like you were like, oh yeah, let's talk about, you were just so not ashamed, just very open. Like girls were talking to you about random stuff in the studio because they're like, oh, she's a
Yeah,
safe
I
person.
love that.
So I always appreciated that about you for sure. So
Thanks.
tell us what you've got going on now. Do you have courses? Are you doing one-on-one,
Don't have
facilitating?
courses.
Okay.
I do one-on-one. I do a few pretty much all so far local, which won't apply to many of your listeners, but I do some workshops and things locally, in-person ones. I don't have any virtual workshops as of right now, but if I do, I'll make sure that I post about those on my social media stuff. I do one-on-one. Everything's one-on-one. So I do whether they're virtual or in person, hour consults or treatments, kind of depends. I am only licensed for PT in California and Oregon. So if I see you outside of those states, it will just be wellness sessions. So so there's a little bit of differences from the legality. I can still see you. It just is terminology changes a little bit and I can't give you anything for insurance. So, but I can see people. My knowledge is still there if you're in Alabama. Yeah.
Exactly.
Yeah.
Exactly. And then what's the best way to get in touch with you? Is that through your website?
Yeah, my website has information, but also if you can Google my name or my business name, Floored Pelvic Health on Google. I'm there. There is a book that another pelvic floor PT wrote called Floored. Don't be confused. She's also a Sarah who's lovely. She works in like Louisiana or something. So it's not me.
Okay.
So if it's a book, it's not me. I did not write that book. She wrote it after my business was already formed. So it's fine. So Floored Pelvic Health and Wellness, Redmond, Oregon. My name is Sarah Tilley. And then I have a website and all that stuff. So you can find me there.
Yeah. We'll link everything up in the show notes. And if any of the ladies on the call are interested too, I can always get them connected with you. But
sounds great.
Well, I'm excited for this episode to release. And I think more women, need to be having the conversation around not only their health, which I'm really trying to do, but most definitely the things that are oftentimes overlooked, which I think pelvic health is a huge one. And, I appreciate the work that you're doing in the world. And, I just want to thank you for being here. And I'm excited for the rest of the podcast people to hear all the good stuff, because it really is one of those things that there's no reason to be living ashamed with a lot of the things that we talked about when help is right at your fingertips and can be, accessed so easily, especially on the internet. So thank you for what you're doing, Miss Sarah.
I love it. I love what I'm doing. Feel free to reach
Yeah,
out with any questions anytime. I'm always happy to chat with people over the phone before they schedule too. So we can
totally.
make sure that happens.
Okay, awesome. Thank you so much, Sarah. Thank you guys for being
Thank
here.
you.
And yeah, we'll probably connect again soon, I'm sure.
Awesome. Sounds great.
All
Good to
right,
see you.
bye. Thank
Bye.
you.